To finish our pharmacokinetics, we eventually have to talk about steady states. You see, really, so far we've looked at the behavior of a single dose of drug. You give the drug at time 0, you measure drug concentration at various time points, and you find a curve that has a classic bell shape, as we've seen. You can define parameters of half-life for that one dose of drug, elimination constant, clearance, and so forth. However, you know well that most often we give drugs repeatedly. And when we do this, our aim is to achieve a steady state. Steady state will occur when rate in equals rate out. And the whole premise of being tested about steady state on the exam is to be tested about what is called the plateau principle. The plateau principle is a statement like all principles that cannot be refuted, which basically tells us that the time it takes to reach steady state only depends on the half-life of the drug. And kind of counterintuitively initially is not going to be dependent on the dose size, i.e. it's not because you give more of a drug that you're going to reach steady state any faster, or less of a drug to reach steady state slower, and it's not even relevantly associated with how often you give that drug. The frequency of administration, whether you give it at very short time interval or very long time interval, will not allow you to speed up the time it takes to reach steady state. It's just purely a matter of half-life. When we look at this, then we can check it out in numbers by using the graphic entitled Oscillations in Plasma Levels Following IV Bolus Administrations at Intervals Equal to Drug Half-Life. Well, now that's a title for a graphic. It takes already 20 minutes just to read the title, but weigh the words in here. The key issue is to try and figure out what happened to blood concentration of a drug if we were to give that drug every half-life. Essentially telling you give a dose of that drug, you wait one half-life, 50% of that drug dose would be gone by then, before you give a second dose. So let's look at the whiteboard one more second. Imagine that we're going to give 100 units, maybe 100 milligram if you want, of a drug. That's the first dose. And we're going to wait one half-life. Those 100 units will have become 50 in the body by the time we give a second dose of drug. When you give a second dose of 100, it will add on to the 50 remaining from the first dose, resulting on the second dose in a peak blood concentration or amounts in the body of 150 units. Now you realize what we're going to do is wait another half-life. 150 would become 75. Now we're about to give a third dose on top of the remainder 75 units that are a combination of what's left from the first dose and what's left from the second dose, giving us now a peak of 175, and so forth. This is represented to you on the graphic, represented as a plot of plasma drug concentration as a function of time. If you look at 100, the first maximal amount obtained in the body after administration of the first dose, we show you then that after one half-life, the actual amount went down to 50. The half-life on the diagram is given as a 4-hour time interval, and the interval of dosing in pharmacokinetic is called tau. So if you want here in our special example, tau, the interval of dosing, is equal to the half-life of the drug and is worth 4 hours. Every 4 hours, 50% of the drug is going to be eliminated from the body. Once I'm at 50, I give my second dose. That second dose adds on 100 and brings the peak concentration to 150. 150 is the peak after the second dose. After one half-life, it goes down to 75. You give a third dose, you get to 175. Another half-life goes by, you go down to about 88. Another 100 units bring you to 188. Another half-life, you go to 94. Another 100 units bring you to 194, and so forth. Notice that progressively, you will reach kind of a magic number, which will be a maximum of 200 and a minimum of 100. From then on, every half-life, the 200 will get to 100. You give 100 units, you'll go up to a 200 peak. Those are known as peak and trough concentration of drugs. And once you have reached those numbers, you are truly at steady state. Now, could you count how many half-lives it takes to reach steady state? Certainly, you would realize that it took 1, 2, 3, 4, 5, 6, 7, more than 7 half-lives before you truly reached steady states. But clinically speaking, when you look at numbers where the minimum would be around 90 and the maximum around 190 to 195, then obviously clinically you are at steady state. You're not going to have that much of a different effect of a drug between 194 and 200, for instance, or between 88 and 100. So that really, when we look at the time it takes to reach steady state under clinical circumstances, we tend to think that it takes 1, 2, 3, 4 to 5 half-lives before we reach clinical steady state. This is very important. What is very important is that it's all a matter of half-life and not of doses or frequency. For instance, if I had given a larger dose, imagine you started giving 200 and you decide to give 200 every half-life, then surely your first point would be 200, but a half-life later you'd be down at 100, you give another 200, you'd be at 300, then 150, then 350, and so forth. All you would manage to do by raising the dose of a drug you give is very much so to raise the plasma concentration accordingly. Remember, after all, dose and concentrations are directly proportional. By the same token, if you had changed the frequency of administration and not taken every half-life, maybe you gave it shorter. Well, certainly if you give it shorter, you're not as low by the time you give your other 100 units. So your entire curve will be bumped up, but it will still take you the same amount of time to reach the steady state. The only difference would be when you change dose or dosage interval is the concentration in the blood will be different, but the appearance of the curve to reach a plateau will be the same. It will require 4 to 5 half-lives for clinical steady state, more than 7 for mathematical type of steady state. So classic clues are given in the margin of your syllabus. You understand that within 1 half-life you've reached 50% of the steady state. Well, to reach to 90% of a steady state takes roughly 3.3 half-lives, not a very useful number unless you want a shortcut for some problems. Key numbers, 95% or clinical steady state is obtained in 4 to 5 half-lives. True steady state, mathematical steady states, requires more than 7 half-lives. As far as rates of infusion, or if you want doses and what it does, remember that irrespective of how much drug you give, you will always take the same amount of time to reach steady state. And this is shown very well on the diagram entitled Effect of Rate of Infusion on Plasma Level, where you see that giving an infusion of 1 milligrams per minute eventually reaches steady state to the right of your figure in 4 to 5 half-lives. Giving 2 milligrams per minute simply realizes a doubling in the blood concentration, but certainly not any speeding up of reaching steady state. Giving 3 times more, 4 times more, 5 times more on the diagram shows you it always takes the same amount of time to reach steady state. Endpoint to reach steady state is all a matter of half-lives. How can we make this relevant for the exam then? Well, various ways. Number one, you remember that half-life is inversely related to elimination. So in turn, elimination also can alter the time it takes to reach steady state. Let's take an example. As I take an example, let's look on the board. Imagine that my drug has a half-life of 5 hours. And imagine that elimination is cut in half. Or, maybe that classic example where we removed 1 kidney. Based on this, how long would it take you now to reach steady state? You know that normally with a half-life of 5 hours, which is a pretty much classical half-life for most drugs given, 4 to 5 hours for our body to get rid of 50% of a drug, it would take you 4 to 5 half-lives to reach clinical steady state. 4 to 5 times 5 hours is 20 to 25 hours. That would be how long it takes under normal condition to reach steady state. which by the way is about a day. So if you can afford it clinically, you take those drugs on the first day. By the next morning, when you take drugs chronically, you probably already at steady state. Contrast a person who has an elimination that is impaired, and that patient doesn't have to undergo surgery. Let's go to something much more common. Does hypertension or diabetes mess up kidney function? I hope you're shaking your head so hard that you're losing your cervicals there. Of course, diabetes, hypertension tend to decrease renal function dramatically. And when elimination goes down, half-life increases. If I cut my elimination by 1/2, my new half-life, my new T1/2 in that patient is 10 hours. And therefore, to reach steady state in that patient will no longer be 20 to 25 hours, but rather 40 to 50 hours before I would reach steady state. Now, don't confuse reaching steady state and how much drug will be in the blood of that patient, because by the same token, when elimination is decreased, remember that more drug will pile up in the body. So now you're dealing with patients that not only take a long time to reach steady state, but you're talking about patients who may have buildup of that drug in their body and potential toxicities. That's why we like to look at elimination function, particularly kidney function in patients before administering and choosing on the doses of drugs. So that's one aspect, the role of half-life in elimination and the reaching of steady state. Second aspect of the issue is going to be the fact that you know it will always take those 4 to 5 half-lives to achieve steady state. What if you don't want to wait to have that effect? What if your minimum effective concentration happens to require a steady state concentration? Really, there's two clinical possibilities there. Either you're going to wait the 4 to 5 half-lives because they're short enough, or you wanted an immediate effect of the drug and you don't want to wait the 4 to 5 half-lives. Well, you can't change the principle, but what you can do is change the dose in order to achieve effective clinical concentration sooner. And that's called using a loading dose. The effect of a loading dose is to more rapidly achieve effective blood concentrations. Very importantly, never understand that a loading dose brings you to steady state faster. Remember, the size of a dose, the frequency of administrations do not alter the principle that it takes 4 to 5 half-lives to achieve steady state. Merely giving a larger dose from the beginning will achieve larger blood concentration, such as the ones you would see upon chronic administration. We can illustrate this using the diagram, effect of a loading dose on the time required to achieve the minimal effective plasma concentration. You see in the diagram a dotted line, and that dotted line represents the minimum effective level of the drug. You see an initial curve showing you that at the dose chosen for regular administration, the first dose does not even reach minimum level and therefore is devoid of efficacy. Waiting a certain amount of time decreases the amount of that first dose. Now you give your second dose. The second dose on the diagram gave you a very little period where the drug had a duration of action, but you still spend a considerable amount of time below minimum level with no effect. Then eventually you have a longer effect and so forth, until once at steady state in our example, you would now have a continuous efficacy with maximum and minimum levels. The effect of the loading dose is to immediately bring blood concentration above minimum level. Of course, it doesn't bring you to steady state, but it gives you a therapeutic effect right from the start. Then if you tweak the dosing intervals and make sure that initially you give your drug before it would dip below minimum level, then you could maintain that patient above minimum effective concentration for as long as necessary until you reach the steady state. Well, this is the effect of a loading dose. And the effect of a loading dose will allow to achieve therapeutic efficacy in spite of the waiting of 4 to 5 half-lives to reach steady state. Now, for the exam, the classic example is to give a drug every half-life. And further, another limitation in the exam example is that the steady state concentration is equivalent to the minimum concentration at steady state. In other words, the trough level. If you have those two parameters, which is it is CSS minimum, that is the effective concentration, and you give the drug every half-life, then truly the loading dose is double the maintenance dose. However, this is the only time you can apply that point. Loading dose is double maintenance dose only if a drug is given every half-life and only if the steady state concentration equals the minimum effective concentration. In any other situation, we'll have to use equations.